Today I welcome you on a pathology lecture on heart. The topic is cardiac hypertrophy, which is leading to congestive cardiac failure. I am from histopathology department and my name is Shazia Mumtaz. Here we can see the learning objectives and types of congestive cardiac failure. As you know, heart is primarily made of muscles. These are muscles made of thick and thin filament, which in turn comprises of actin and myosin filaments. In heart, there is a cardiac cycle. There is a systole in which contraction of the cardiac muscles results in ejection fraction, that is the stroke volume pumped by the heart with each heartbeat. Diastole is the phase in which heart receives all the blood from the periphery and relaxes, and in this diastole period, it receives its blood supply. Intercalated discs are the junctions between the cells which allow passage of iron, sodium, potassium to allow electric conduction or conduction of between SA or AB node. What is the normal weight of the heart? It is between 250 to 360 grams in adults, and the ventricular wall thickness is different in the right ventricle and left ventricle. As the left ventricle is pumping more blood, its muscle is more thicker, that is 1.3 centimeter to 1.5 centimeter, while the right ventricle average thickness is 0.3 centimeter to 0.5 centimeter. This also corresponds to the function they are performing in cardiac cycle. So before discussing, I give you overview of the cardiac pathologies, the brief mechanisms which can result in different types of cardiac pathology. The first one is pump failure, in which in this condition myocardium contracts weakly during systole, and there is inadequate cardiac output. And what is the cardiac output? Cardiac output is the ejection fraction or the stroke volume pumped by the heart with each heartbeat. In addition, the pump failure can also be result of incomplete relaxation, which is the diastolic failure. That is, pump failure can be due to contractile dysfunctions, or it can be resulting from diastolic dysfunction, that is inadequate relaxation. Coming to the second mechanism is the flow obstruction. Obstruction within the blood vessels, that is any plaque is formed within the blood vessels, that is called atherosclerosis, or it can be anything which is preventing from valves from opening, or for example thickening of the cardiac walls. So it can be either of the two conditions. Examples can be aortic valve regurgitation or hypertension. In hypertension, what happens that there is increased blood pressure within the vessels. So heart has to pump more with more force against this pressure which is present in the vessels. So in this way we can say it is indirect flow obstruction to the heart, ejection fraction. Now regurgitation is in simple meaning is a mixing of the blood flow. Portion of the cardiac output from each contraction flows back through the incompetent valve. Taking the example, for example, rheumatic heart disease or aortic valve incompetence, if valve is not able to close properly, then obviously it results in backward flow, which is called regurgitated flow back into the heart. Now, the another mechanism is shunted flow. There is shunt is defined as abnormal communication between the cardiac chambers or in between the two vessels. Normally, what happens in between the vessels, there is a capillary network. But what happens in this shunt, this communication, both the vessels are communicating with each other. without capillary blood, without capillary network. Next is the disorder of cardiac conduction, SA or AV node, or last one is rupture of major vessels or heart. Now coming to our main topic, these were the mechanisms in which heart failure or heart dysfunction can result. Now heart, I told you earlier about the normal cardiac weight in adults. Hypertrophy is denoted as increased weight of the heart, while cardiac dilatation is increased cardiac size as compared to normal. Now the third terminology is cardiomegaly. This can be due to increase in size of the weight or increase in weight of the heart. So we need to memorize the normal heart rate to compare it during the, for example, any autopsy's conduction to know that it's a hypertrophy or not. In cardiac dilatation, it is not necessary the heart rate also increases. Heart rate can be slightly increased or even normal in size. Only heart chamber, 4 chambers are dilated. Here is a picture of the cross section of the heart. This one is more thickened, so that it will be left ventricle, and as compared to this is the less thickening. You can appreciate 0.3 centimeter. I told you about the right ventricle. So this is cross section of the normal heart ventricles. Here you can appreciate the valves and attachment of the valves. Now coming to our main topic is a congestive cardiac failure. What is congestive cardiac failure? Congestive cardiac failure is a term in which a heart is unable to pump blood at a rate sufficient to meet the metabolic demands of the body. So in simple words, what I say is, what is the normal function of the heart? Its function is to pump blood so that adequate blood reaches at a rate which is sufficient for the tissue oxygen and nutrient demands. If if heart is pumped but it is not pumped at a sufficient rate, then there is a problem, and this is also called congestive cardiac failure. Or the other condition can be that the blood reaches the periphery of the tissues, but it reaches only with the elevated filling pressure in the heart. So either of the two can be a result of congestive cardiac failure. CCF is a short for congestive cardiac failure. What are the mechanisms of the congestive cardiac failure? We are going to discuss each one briefly. Mechanism taking first is chronic increased workload. The workload of the heart can be increased by how? What is the normal working of the heart is pumping blood, and pumping blood, it takes support from the valvular, aortic and mitral and other valves. So any disease which disrupts the valve or damages or stiffens the valve of heart can increase the work of the heart, and eventually heart can fail. I told you other example of hypertension. If there is in hypertension, what happens? There is increased blood is in the vessels is under increased pressure. So the heart has to pump against this increased pressure to provide blood to the peripheral organs. So in this way, heart work is increased as compared to normal. Second mechanism is ischemic heart disease. Ischemic heart disease, in ischemia, what is the normal definition of simple term is ischemia? Lack of blood supply. If heart in itself is damaged due to ischemia or myocardial infarction, it can eventually result in congestive cardiac failure in a long run. Third mechanism is acute hemodynamic disturbance. For example, if we give excessive fluid overload in ICU patients, or renal failure patient. Such condition, it can result in more blood in the circulation, and eventually heart has to pump more volume back into circulation. In this way, the heart has to work more, and eventual CCF will result. Other mechanism is abrupt myocardial infarction or valvular dysfunction. In this scenario, also there is a hemodynamic disturbance, and the blood is entering directly into the pericardium and into the periphery of the body systems without oxygenation. One scientist was Frank, and he described this mechanism, which is responsible for maintenance of the organ perfusion of the peripheral tissues. In this I take the example of a rubber band. If we consider heart as a heart muscles as a rubber band, and we pull it and till its capacity, and we leave it, then it will recoil back. So the heart has similarly has got certain potential, so it can, if increased blood is pumped into the heart, it recoils back with more effort, but this capacity of a heart is limited. If this goes on for prolonged time, this can result in congestive cardiac failure. I just briefly describe you. Increased filling volume, for example, any drips or fluid overload, it dilates the heart. Increased cross-bridge formation between the actin myosin, and just I told you that just like a rubber, it requires back increased contractility, and where increased contractility means increased pump of increased blood pump into the periphery, increased stroke volume, which we can say, and increased stroke volume means increased ejection fraction of the heart. The heart blood volume pump with each stroke of the heart. So this is the Frank-Starling mechanism, which is responsible for maintenance of the normal pumping in the cardiac cycle. And this also tells us the response in which heart interacts, response to the increased volume of the blood. So this is a physiological mechanism. But this mechanism also has certain limits. If certain limits are reached, it goes for a prolonged period, it can result in CCF. Adaptation, heart is adaptable. It can increase its increased workload can result in hypertrophy of the cardiac muscle, including cellular and structural changes in the heart. Even at the molecular levels, certain genes are induced. This is called ventricular remolding of the heart. Another adaptive mechanism in the congestive cardiac failure is neurohumoral mechanism. First is the famous one is the increased norepinephrine is secreted by the increased norepinephrine is secreted in which can result in increased contractions of the heart. This is secreted in response to decreased blood pressure sensed by the neurosensory receptor. Another mechanism is the renin-angiotensin-aldosterone mechanism. The increased renin production and renin-aldosterone is secreted, which is responsible for maintenance of the fluid in the body circulation. The third mechanism is atrial natriuretic peptide. This is a hormone secreted by sensory receptors in the right atrium, which can sense the low blood flow, and this is secreted, and this is also responsible for maintenance of the normal pressure, bringing pressure back to normal in response. Now, first we discussed the definition, then we came back to the mechanism which are responsible for hypertrophy or congestive cardiac failure if these fail. Now coming to the classification of heart failure, these can be classified as systolic or diastolic depending on the function. Systolic dysfunction is contractile dysfunction of the heart. Diastolic is in diastolic dysfunction, heart is unable to relax properly. Now it can be right side, involving right side of the heart anatomically, or left side of the heart. So most of the systolic dysfunctions are result of left-sided heart failure. As we know that heart is a both sides of the heart, there's a cycle going on. Eventually, if one side of the heart is failed, it can result in eventual collapse of the other side as well. This is when this happens, both sides of the ventricles are involved. That's called biventricular failure. It can be starting from biventricular. It can be from the start, or it can be most commonly it is result from left side heart failure affecting the right side, leading to right-sided heart failure. Sorry. Now, systolic and diastolic dysfunction, the causes in this, I show you the common causes. Systolic dysfunction, the common cause is hypertension, valvular heart disease. In diastolic dysfunction, there is constrictive pericarditis or amyloidosis. In constrictive pericarditis, heart is unable to relax because what happens? Pericardium is the curved ring of the heart. If any inflammatory conditions or primary pericardial condition or uremia which affects the pericardium, it stiffens the pericardium, leading to fibrosis, and heart cannot relax back in its pericardial sac. So in this way, this is diastolic dysfunction can result, and in this heart cannot fill up during diastole. So end result will be less filling and less output by the heart, decreased ejection fraction in this diastolic heart failure as well. Amyloidosis is an autoimmune condition in which this material, amyloid, eosinophilic amorphous material, can be deposited in any tissue of the body. When it is deposited in the heart, its deposition lead to stiffening of the heart muscles, and eventually heart muscles fail to relax and diastolic dysfunction ensures. Another mechanism of congestive cardiac failure is forward failure or backward failure. Forward is decreased cardiac output, that is decreased ejection fraction, decreased stroke volume, and backward failure in this pooling of the blood in the venous system of the circulation. This we already discussed, right, left, and biventricular failures. What happens in hypertrophic congestive heart failure? I told you earlier example. In this, I have shown you arrows. Take these arrows as cardiac muscle. In this, the heart cardiac muscle hypertrophy in a such way that these are sarcomere are arranged perpendicular and concentric hypertrophy of the heart cells. In hypertrophy, because it's proportional in supply you weight. It can be hypertrophy, can be physiological during exercise and aerobic. It can be result in weight lifting as well.
डॉक्टर शाजिया, आपकी प्रेजेंटेशन स्क्रीन पे नहीं आ रही, काइंडली चेक कीजिए।
मेरे पास आ रही है एक्चुअली।
यहाँ डिस्प्ले पे नहीं आ रही है, स्टूडेंट्स को भी नहीं दिख रही।
नहीं दिख रही है। तो दोबारा से चलाएं फिर इसको।
आप उसमें शेयरिंग के ऑप्शन में जाइए, शेयर स्क्रीन के ऑप्शन पे जाइए।
एक मिनट, फिनिश कर लूं पहले।
इसको ऐसे ही मिनिमाइज कर लीजिए।
मिनिमाइज कर लिया मैंने। अब दोबारा ज्वाइन करना है इसको।
ज्वाइन नहीं करना है, शेयर स्क्रीन का ऑप्शन दिख रहा है आपके नीचे, शेयर स्क्रीन।
एक मिनट, ज्वाइन अ मीटिंग का ऑप्शन दिख रहा है।
मीटिंग तो आपकी ऑलरेडी ज्वाइन हुई हुई है, आप बात कर रही हैं मुझसे।
हाँ, तो आप किस तरफ कह रहे हैं कि आप एक कर्सर आ रहा है जिसमें वो लिखा हुआ है।
देखिए ऊपर ऑप्शन आ रहे होंगे, कर्सर ऊपर ले जाइए।
ये तो मेरी प्रेजेंटेशन। We were discussing congestive cardiac failure. Sorry for the interruption. Now we are going to continue with hypertrophy. I told you in pressure overload or volume of hypertrophy, the cardiac sarcomeres are arranged perpendicular, and the hypertrophy we say is concentric hypertrophy. Examples are systemic hypertension, aortic stenosis. We discussed heart weight will increase and why it's important and how it leads to ischemia. Morphology of the heart, gross morphology will be depending on the cause. The heart, you can weigh the heart, you can measure the size. It can be hypertrophy, heart. You can look under the microscope. Cardiac hypertrophic muscle can be easily identified. A thinned out cardiac muscle can be identified. In myocardial infarction, surrounding normal myocardium is usually hypertrophic, and in the center you can see the ischemic changes with loss of nuclei in the myocytes. In valvular heart disease, if that's a cause of congestive cardiac failure, heart tends to be globally dilated as compared to hypertensive heart disease, in which left side of the ventricle is more thickened, and that's understandable also. Hypertrophy, I told you, can be physiological as well. Volume overload hypertrophy leading to congestive cardiac failure. In this, the new sarcomeres are arranged within the existing sarcomeres. So this arrangement is you can say is haphazard. So heart will be usually thinned out and globally enlarged. And the arrows are showing that haphazard arrangement. The wall thickness, when we look at, can be increased, decreased, or it can be normal. Coming to common causes of the left-sided heart failure, most frequent cause is ischemic heart disease of the heart itself, systemic hypertension, atrial mitral valvular disease, and primary myocardial disease. Left-sided congestive cardiac failure. Clinical and morphological effects are consequence of passive congestion. Blood is pulled back in the pulmonary circulation. Stasis of the blood in left side of the heart chambers, inadequate perfusion of the downstream tissues leading to organ dysfunction. Why this blood is pooled in the pulmonary circulation? Because the blood is not effectively pumped back during the ejection fraction. And there is stasis of the blood in left side of the heart chamber. The blood pooling is there. So in the end, the organ perfusion is compromised. Passive congestion in congestive left-sided heart failure leads to pooling of the blood in pulmonary circulation. Lung we see are congested, edematous, decreased ejection fraction, decreased perfusion of the organ. Let's say example of kidney. Kidney will, as you know, that can sense decrease in pressure. This is false sense of hypertension, as there is no blood volume loss. However, it can still activate the renal angiotensin mechanism, and that leads to further increase in blood pressure. When renin activates angiotensin, and angiotensin is converted into angiotensinogen and acts on the peripheral organs, increases the vasoconstriction, leading to more pressure in the periphery, more blood pressure in the more pressure in the vessels. So in this way, it's initially it's helping, but later on it's also affecting in a negative sense, because it's increasing the workload of the heart, as heart has to pump against more pressure in the vessels. Signs and symptoms are results of passive congestion. In lungs, there's pulmonary congestion, edema. We can say these are lungs will be heavy, wet, perivascular interstitial edema, widening of the alveolar septa, RBCs and plasma proteins extravasation. There will be heart failure cells and pleural effusions. Now, what are heart failure cells? Heart failure cells are the macrophages which come to the lung parenchyma, and as there is a plasma protein and RBC leakage, these macrophages then engulf RBCs, and mostly these are seen in left-sided heart failure. There will be pleural effusion. This can be diagnosed in X-ray. In kidneys, there will be pre-renal azotemia, nitrites, and other metabolites are being accumulated, salt and fluid retention, as the kidney is perceiving as fluid loss, as I already discussed. Activation of renin, angiotensin, and natriuretic peptides are accumulated. As coming to the brain, as brain is not receiving proper blood supply, and byproducts, metabolites are there in the blood, brain will be irritable, decreased attention, stupor, and coma eventually can result because of left-sided heart failure in end cases. Here's a picture: dyspnea, orthopnea, paroxysmal nocturnal dyspnea. Patient can cough, blood tinged sputum, and cyanosis can be there. Now coming to morphology in heart, depends on the cause. What is the cause there? Like ischemic will show ischemic changes if causes due to valvular dysfunction, then you can identify vegetation, or in rheumatic heart disease you can identify calcification, incompetent lungs. In lung, perivascular and interstitial edema heart failure cells, as already discussed. Now, left-sided heart failure cells can be due to different mechanisms: systolic and diasystolic. Diastole is during diastole, in complete relaxation, stiff heart fail to relax, while systolic is fail to contract. So if it happens during diastole, left ventricular cannot expand normally. It therefore results in increased filling pressure, immediately transferred to pulmonary circulation, leading to pulmonary edema called flush pulmonary edema. The left-sided diastolic heart failure are more common in women above 60 years, mostly is the age range. Hypertension is the commonest cause. Other causes include diabetes, mellitus, obesity, bilateral renal artery stenosis. And when considering heart, myocardial fibrosis, cardiomyopathies, ischemic heart disease, restrictive cardiomyopathy also come in left-sided diastolic heart failure dysfunction. Here we end the left-sided heart failure. We discussed the in left-sided heart failure we discussed the signs and symptoms, morphology in each organ, mechanisms, and types of systolic and diastolic both. Now coming to the right-sided heart failure. It's less common as compared to right side. Left side heart failure is frequent causes left heart failure itself. Less frequent is any pathology in the pulmonary circulation. For example, pulmonary is a pulmonary obstructive disorders or disorder that increase pulmonary hypertension, vasoconstriction. Causes I have listed here, but these are not the end of the list. You can find and search out more causes. Primary pulmonary hypertension, recurrent thromboembolism disorder that increase pulmonary vasoconstriction. Again, pulmonary hypertension, more blood is under more pressure, so heart has to pump against this pressure. Recurrent thromboembolism mechanism is that more thrombi in the vessels, heart has to pump against more obstructed vessels. Another one is pulmonary disorder that cause pulmonary vasoconstriction. So vasoconstriction is also understandable as it increases the lumen, increases the pressure in return. Mechanism: left-sided heart failure is a cause of right-sided heart failure. Eventually, when heart fails from the left side, pressure raises above, and also it secondarily involves the right side of the heart. Pulmonary causes I briefly described here. Disorder increase pulmonary vasoconstriction, increased pressure in the pulmonary leading to increased pressure in the pulmonary circulation, leading to pulmonary hypertension. Sign and symptoms: pulmonary congestion is minimal, while systemic effects are more. Like mostly effects are due to pooling, like in liver increase, passive congestion, nutmeg liver, congestive splenomegaly, ascites. In kidneys, similar effects can be seen in left-sided heart failure. In pleura and pericardium, the fluid will accumulate due to backward pooling in the pulmonary circulation, which is transmitted back into the pleura and the pericardium, and mostly in form of transudate. That is, the effusion is not inflammatory. Peripheral tissues pooling. Lung can also be affected. There will be dependent edema in the necks. When we see the pulse and jugular venous distension, we can observe in the neck. Hepatomegaly, cyanosis, peripheral CNS can be affected, in turn, increased peripheral venous pressure. With a brief diagram, patient is fatigue, dependent edema, distension of the JVP, liver engorgement, ascites, anorexia, as the GIT is also involved, spleen, liver, cyanosis, elevating pressure in the peripheral veins, pitting edema. This is the last diagram. I think this is the pitting edema. Here you can observe the heart failure cells, which I described in the alveoli. These are the alveolar linings. In the center, you can observe the brownish pigment, which is due to leakage of RBCs in the lung alveoli. This is liver. Here you can see small micro dots, nutmeg liver. And here is also liver histopathology. There is necrosis. Central area is viable and periphery is necrosed. So center is relatively preserved because of vessels are close to it, while periphery is, which is far away from the central vessel, is obviously more compromised and ischemia results. Here we end. Any questions? Any questions? Here we end our topic of congestive cardiac failure and hypertrophy. Thank you, everyone, for the attendance.
Thank you, ma'am. Thank you.